practice a rhythm and rush these days with a light.
Good morning. My name is Yamini Saravanan. I'm a primary care doctor at the Cambridge Health Alliance, and I'm standing here in front of you today because I had a professional crisis. A crisis about 2 years ago where I had started feeling more and more disconnected from a group of my patients. I couldn't really make sense of their illnesses, their needs, their lives. Their healthcare lives were filled with a constant hum, frequent no-shows with me, with other providers, frequent visits to the emergency room, admissions, readmissions, and an increasing list of diagnoses, both medical and psychiatric in nature. Nationally, we call these patients complex or high risk. The Agency for Healthcare Research and Quality reports that about 5%, just 5% of our population accounts for about 50% of all costs. Complex patients tend to have Medicaid or Medicare. They have more chronic conditions, are prescribed more medications, and do utilize hospital services more, like the emergency room. Another study showed that when you ask these patients, well, do you feel better? Over half of them actually say that they perceive their physical health to be only fair or poor. So my panel of patients, I realized, were actually quite typical and part of a national dilemma and ongoing conversation. Around this time last year, I had the opportunity to sit in on a diabetic group visit. I was sitting next to a patient who had been asked to share her story. She sat up straight. She said, I am a Marine. I am a strong woman, and I am disgusted by my diagnosis of diabetes. I am disgusted by the medications I have to take because they make me feel like a failure. And so, I deny it. This was the first time as a physician, as a provider, I had heard a patient share their story with illness. It was powerful. I'd realized that I had authored many a medical story in the form of the many medical visit notes that we write. However, they were peppered with judgment and labels as to whether a patient was actually doing what I'd asked them to do. And if they didn't, I labeled them non-compliant, non-adherent, non-engageable to care. This project focuses on collecting, on understanding, and sharing the stories of these patients. We believe that these stories from the patient's voice, from their perspective, will create stronger relationships between the provider and the patient, and will help us as healthcare teams understand the needs of our patients. We started with a list of 25 names, all patients of a Medicaid subsidiary who had gone to the emergency room about 15 times in a 6-month time period. We spoke to 12 of them. We heard their stories in their homes, in shelters, in our offices. Kelly is one such patient. She's 41 years old, a single mother of 3, strong, funny, resilient, grew up around Boston her entire life. She shares with us her story, her childhood filled with sexual abuse from her father, rape, poverty, foster care, in high school forced to join the neighborhood gang. We ask her about healthcare. She says she likes her entire healthcare team, but she feels misunderstood. No one gets me, she says. No one really understands where I come from. Kelly is petrified to leave her house. She cannot go to a doctor's appointment unless accompanied by one of her school-age children. She tells us that her 8-year-old daughter has missed 52 days of school because this 8-year-old child went with her mother to emergency room visits and doctor's visits. About the emergency room, Kelly chuckles. They call me a frequent flyer, she says. She goes to the emergency room in severe abdominal pain, with uncontrollable vomiting, a condition for which she's been evaluated by multiple providers and specialists, but she still says, I don't know why I have this. She's grateful to the care she receives in the emergency room. They make me feel better, she says. They give me IV fluids, they give me some IV pain medications, but she's also frustrated. I go there in pain. I take the ambulance, but that sometimes at 2 a.m. they discharge me. There are no more cab vouchers, and so she and her 8-year-old daughter walk 3 miles back home, sometimes at 2 in the morning. We asked Kelly to share with us a healthier time in her life. She's quick to remember one. It was a time when she lived in another neighborhood, where she said she could keep the back door open, where it was peaceful. There were no gangs, no shootings, where her children, she says, went to school with other rich kids, where they had a chance. Kelly's life is challenging. She's worried about whether she has money for food, her medications, her children's medications. She's worried about her son and his recent admission to the hospital. She's worried about her safety, her children's safety. Kelly's goal is to get better. She wants to be a wonderful mother and keep the kids out of the streets, as she says. Kelly is one story. We spoke to 11 other patients carrying equally heavy loads. 8 of these patients are women, 4 men between the ages of 23 and 58. They also happen to be carpenters, to be mothers, grandmothers, fathers, one-time models, addiction counselors. All 12 of these patients reported financial worry. They all were worried about their ability to pay for food, rent, medications, daily needs. 11 out of these 12 patients shared with us a childhood instability, a parent with addiction or mental illness, being raised in poverty. 9 out of these 12 patients shared with us a history of emotional, physical, and or sexual assault at one point in their lives. Over half of these patients said that they were lonely. They didn't have a single soul, a single person, friend, family member to call, to lean on. They wondered, would anyone know if I died? What do I take away from these stories? My patients are complex. Their stories, deep. Their healthcare utilization, costs, however, is not just a healthcare problem, and treating it as such would be an injustice to these patients. My next step is to understand, how do I share Kelly's story with other key community partners? How do we get her community public health department, her police force, maybe her children's teachers to this table to hear this story, to improve her sense of well-being, not just for Kelly, but to prevent the cycle of complexity from affecting her children. My next takeaway is a simpler point and a question I pose to all of us. When we care for our sickest, our most vulnerable, sometimes our most misunderstood patients, why don't we start by crafting a story? A story from the voice of the patient, unaffected by our own judgment. This might be a beginning, a small one, to form a bridge between our perceptions of what we think a patient needs to their own narratives of illness, but more importantly, their hopes for health. Thank you.